Okay. Okay. So we'll get started. If you remember, inhibitory neurons, GABA, chloride comes rushing in. Why? What does chloride do to make it inhibitory? What higher? So remember, chloride is a negative ion. It's going into the cell, so the cell will become more negative, making it further from threshold, so harder to stimulate. The termination of our signal is either you remove the neurotransmitter from the cleft, you can metabolize the neurotransmitter, break it back up, but you have to be able to stop the transmission as well. So here is our terminal end plate. Signal comes down, active potential comes down. What type of receptors are going to be here? What kind of channels for ions? What all live right here? This is where calcium channels are, right? Calcium channels are at the end. Why? What's calcium going to do when calcium comes into the exocytosis of the neurotransmitter? So all those vesicles have to get released. Calcium is what does that. And that's why the calcium channels are all there towards the end. We have our synaptic cleft and we have the postsynaptic membrane, where obviously it's going to bind to. Here's our synapse again. For our excitatory, it's going to be sodium. Glutamate is the major excitatory neurotransmitter of the brain. GABA is the major inhibitory one of the brain. Astrocytes, they help with metabolic, immunologic, structural support, nutritional support for these neurons. They're not electrical cells, they're not going to conduct any electricity, but they help the nervous system work. But we bring it up because you can have cancer of these astrocytes. Astrocytoma is a very, very malignant brain cancer. Astrocytoma, it's coming from these astrocytes, is where the cancer cells are forming. So we have all these astrocytes there to help with that. Here's a picture of the astrocyte, again, hanging out on the edge of these neurons. They provide the scaffolding structure to support the neurons in place. Oligodendrocytes and Schwann cells, same thing, they make myelin. Oligodendrocytes are in the CNS, Schwann cells are in the PNS, but they both make myelin sheath. We have the little gaps along. They're called the nodes of Ranvier, and that's what helps saltatory conduction, so it goes faster and propagates the signal downstream. Microglia, main function is immune system. So think of that, affected by brain injury, infections, and so forth. Helps destroy dead tissue, remove it away, so it's more of an immune system. Functional neuroanatomy. Our motor system. Motor system starts in the brain and it goes down to a muscle. So it starts in the brain and it goes down. The upper motor neuron starts in the brain, it goes all the way down your spinal cord, where eventually it's going to synapse in the spinal cord to the lower motor neuron. Think of this like the wiring in the wall that goes from the breaker box, like your brain, goes all the way to the outlet on the wall. And then when you plug in your charger, you are connecting a lower motor neuron to the outlet. You're causing a synapse, a junction to occur, communication between the upper and lower motor neurons. In our body, it occurs in the spinal cord. As a real world example, think of electrical. You plug in your phone charger into the wall. That is the lower motor neuron working. All the upper motor neuron axons that leave the brain and go down the spinal cord, they follow the pyramids, the pyramidal tracks. Talked about a little bit of those in neuro over the summer in physio. So the pyramidal tracks, they follow a normal motor system pathway. When we talk about motor system, this is voluntary, so you are able to move your body. We have a couple of different types. You have corticospinal. The way that all the neural tracts are worded tells you the direction that they're going. Corticospinal starts in the cortex and goes down to the spine. So we know it starts with the brain and it works its way down. Corticobulbar, brain to the medulla. Again, we're going from top to bottom. We're leaving the brain, we're going somewhere else. The extrapyramidal neurons, these are responsible for coordinated movement, but these are outside the pyramids. They're called extrapyramidal. As you start going through drugs with Dr. Wood, you may start hearing some side effects called extrapyramidal side effects. That means that the drug that you're giving may cause that patient to have some motor problems, but it's not coming from the motor system, it's the coordination movement. So your caudate nucleus, your putamen, subthalamic nuclei, substantia nigra. Okay, what's in there? Dopamine. So movement. If you're lacking in that area, it's not a motor system problem, it's a coordination substantia nigra problem with dopamine. So those are what extrapyramidal means versus pyramidal. So I mentioned before, we have our lower motor neuron in the skeletal muscle. So the lower motor neuron leaves the spinal cord and it's going to synapse on a muscle. It's a lower motor neuron, so it's got to go to a muscle. Each motor neuron has about 200, will contact to about 200 muscle fibers, and together they call a motor unit. Each muscle is supplied by at least two nerve roots. That's why it's like C3, C4, C4, C5. Which one is it? And motor fibers are arranged in plexi. So we have a brachial plexus and whatnot to allow you to do things with one nerve. Lower motor neurons, the final pathway for all voluntary movement. If you damage the lower motor neuron, will cause flaccid weakness of the innervated muscle. So the lower motor neuron, if you damage that, whatever muscle it's going to innervate will go immediately flaccid. So that's why knowing your nerve roots. Eventually we'll talk about like foot drop, where people are walking and they can't, dorsiflex their foot. You guys have them do walk back and forth in tandem and different other tippy toes and whatnot. Some people will have nerve damage and they have foot drop and they can't dorsiflex. The foot will fall, foot drop, every time they try and do it because the muscle is damaged or the nerve is damaged. Muscle tone, resistance to passive movement is reduced. So when you do your passive range of motion, they're not even providing any type of resistance at all to you. DTRs can be impaired or lost. The neuromuscular junction is the point of contact between the nerve terminal and the muscle fiber. Everything is acetylcholine. And what kind of receptor is it going to bind to? It's a skeletal muscle. Nicotinic. It's skeletal muscle, so it's nicotinic. And removed by acetylcholinesterase to remove and metabolize the neurotransmitter. These are a couple of diseases, so you got to start knowing these now. So these are the diseases we're getting to. So disease of the neuromuscular junction. Is the nerve able to communicate with the muscle? The first disease is called Lambert-Eaton myasthenic syndrome, or just Lambert-Eaton syndrome. What this disease is, antibodies to the calcium channels inhibit calcium entry. If you don't have calcium getting in, what's not going to happen? Neurotransmitters won't be released. If neurotransmitters are not released, will that muscle do anything? No. So Lambert-Eaton blocks the calcium channels to prevent vesicles from dumping out their contents. Aminoglycoside antibiotics, things that end in mycin, gentamicin, daptomycin. Okay, hopefully those names sound familiar by now. Will also impair calcium channel function. It can cause a similar syndrome. So here's an important drug. These class of drugs, the mycin and aminoglycosides, can cause some muscle weakness because it blocks the calcium channels as well. Clostridium botulinum, what's that? Botox. Okay? Cleaves specific presynaptic proteins, and Botox prevents the neurotransmitter release at both the neuromuscular and cholinergic synapses. So botulism prevents the release of neurotransmitter, therefore the muscle will not contract. Yes?
Lambert-Eaton syndrome, and then, okay, so when you have Lambert-Eaton syndrome, is that just like a permanent thing?
I don't know if it's permanent or not, but I think they can give some medicine, but I'm not sure.
Because with the antibiotics, obviously.
Well, yeah, underlying cause, you just stop it and it goes away. Lambert-Eaton, it's an autoimmune problem. They're attacking your own calcium channels. So Botox prevents the release of the neurotransmitter, therefore nothing is telling the muscle to do anything, nothing's going to happen. So when you give it in, the forehead, your forehead muscles won't crease, therefore you don't get wrinkles. That's the thought of that. Myasthenia gravis is another one. This is an autoimmune disease. Autoantibodies to the nicotinic acetylcholine receptor. Is this a presynaptic problem or a postsynaptic problem? Post. So myasthenia gravis attacks the postsynaptic receptors for acetylcholine. So acetylcholine has nothing to bind to, nothing to tell the muscle to do anything, and you get weakness and paralysis. So these are all diseases of the neuromuscular junction. The end result is the same, the muscle's not going to work. But the underlying cause is what's important, what caused that to happen. So here's a good slide that kind of shows, here's your Lambert-Eaton antibody and your aminoglycosides. They're going to attack the calcium channels. Here's our Botox, which binds up here and prevents the release of all those neurotransmitters. And then we have our myasthenia gravis, which occupies the receptors to prevent acetylcholine from binding. All three affect no muscle stimulation, no muscle movement. Upper motor neurons. This is the electrical going from the breaker box to the outlet itself. So this is the motor cortex, starts up there and terminates with the medulla or the spinal cord, depending on which level you're talking about. So groups of neurons are organized in vertical columns. They're like little Ethernet cable. They have a bunch of different wires inside. And as they go to different levels, they pop off and they go to the muscles they have to innervate and they work themselves down. So where these vertical columns, where do you think they're going to be thickest? The top cervical area or down by the lumbar area? Cervical. That's where they're the thickest because they're the most neurons that haven't left yet. When you get down the spinal cord, every level more wires come out. So when you get to the bottom, you don't have much left anymore because you've already gotten them all out to innervate the body. Upper motor neuron damage, upper motor neuron lesions will cause pattern of limb weakness and change in tone. So you have to know the differences between an upper motor neuron lesion and a lower motor neuron lesion. They have different symptoms. Lower motor neuron, immediate flaccid paralysis. Because you sever the nerve, the lower motor neuron, nothing's communicating, nothing's going to happen. With an upper motor neuron, the arms will be flexed and pronated. The legs are extended. So flexed and pronated. Like this, arms about like this. Well, flexed and pronated, so like this. No, they're flexed like this way. It's contracted. We'll talk about different diseases that happen with different contractions later on, especially with like hits in football. So you can see here, our one motor neuron starts in our cerebral cortex. Is it going to start in the precentral gyrus or the postcentral gyrus? Pre. Pre is motor, post is sensory. So the precentral gyrus is all motor. Homunculus, we know it's all mapped out. If we're talking about our legs, it's one part of the brain, sends one nerve all the way down till it gets to a certain level at the spinal cord, and then it branches off. So the nerves that go to your legs, you have one long nerve that goes from your brain all the way down, all the way down your spinal cord, all the way down almost like, L3, L4 is where it kind of stops. One long motor nerve. Sensory is broken up into a couple layers. Okay, so moving on to the brain. So gray matter, cell bodies. The white matter is all the axons. It has the fat on it. Brain is different parts. We have the cerebellum. That's coordination of muscle groups, stance and gait, regulation of muscle tone. So cerebellum is under what effect? What toxic substance greatly affects the cerebellum? Alcohol. What symptoms do you have with alcohol? Uncoordinated movement. Okay, start thinking about real life things. Okay, cerebellum is for that. When you're drunk, these are what happens to you. That's what happens to the cerebellum with damage. So ataxias, delayed movements, the rate of acceleration and deceleration are decreased. So they get very sluggish. They may get an intention tremor and dysmetria. So an intention tremor is, what do this finger to nose? It's purposeful movement. An intention tremor means as they're getting closer to you, the tremor gets worse. It's with movement, purposeful movement, with intention, the tremors get worse. And overshooting, you overshoot your target. So with that finger to nose, they're not going to point out right away. If the lesion is unilateral, the limb ataxia appears on the same side. When we get to strokes and issues like that later on, it's very important to know what side of the body is affected, because we have to know what side of the brain innervates that and causes the problem. If the lesion extends to the midbrain, ataxia also occurs on the side opposite. So if it gets to the midbrain, it can affect both. Basal ganglia, initiation, amplitude, and speed of movement. So if they have a problem with the basal ganglia, when you have them walk into a corner, first it's going to be very slow. And when they get to the corner, they're not just going to hit the corner and turn around and move. They're going to have to stop and purposely change their direction. So other things with the basal ganglia, motor deficits, bradykinesia, slowing of movements, akinesia, loss of voluntary movement, loss of postural reflexes, so they can't keep their body upright to maintain equilibrium, so they start slouching over. Rigidity, tremor, involuntary movements, these are all disorders that may happen. These are all different types of movement disorders. Athetosis is hand writhing, meaning that the hand just starts doing this thing. Like a snake-like. That's athetosis. The hand just keeps doing that. Bulismus is violent movements. So they're usually the proximal, so the shoulder would just flail. It just out of nowhere, it just randomly happens. That's bulismus. Dystonia is repetitive muscle contractions. So they can happen to like the SCM. They get a little torticollis going on from all the twitching. So these are all other issues that result from lesions in the basal ganglia. Neurotransmitters in this area include acetylcholine, GABA, and dopamine. Wherever you see dopamine, just know it's going to be coordinated movements. Here's just the different areas broken up. So remember, our primary motor cortex is the precentral gyrus, and then the postcentral is your somatic. So sensory areas, always post-central. Remember also where our visual areas in the very back of the brain, visual cortex is in the occipital part of the brain. Primary auditory complex, so where we hear things. Wernicke's area is comprehension of speech. You are all listening to me. Hopefully you're comprehending what I'm saying. Your Wernicke's area is the one that's responsible for that. Broca's would be in the motor area because it's motor of your mouth. The actual movement of the muscles requires the motor area for that. Spinal cord, parts of the CNS that extends from the base of the skull down the canal, surrounded by membranous tissue called the meninges. So we got some layers of those. And spinal cord has cells, the nerve cells, the gray matter, the tract, the axon, those are going to be the white matter because of the fat. Remember also, the dorsal posterior horn is always going to be afferent sensory. The ventral anterior horn of the spinal cord is always efferent motor. Okay. The spinal nerve root is when the sensory and the motor combine to make one nerve root that leaves the spinal cord. That is a mixed nerve, has sensory and motor, but they both start at different parts of the spinal cord. So here we have your ventral anterior area. This is all motor. We have our sensory that has a sensory ganglia here, so it always has this little ganglia. Has it on both sides. This is the sensory, and then they come together to be the nerve root or spinal nerve that comes out, but it's a mixed nerve. It's got sensory and motor built in. So always, the dorsal root is always sensory. Ventral anterior horn is always going to be motor. Spinal cord, we have our meninges, the 3 layers. Dura is the outermost layer, arachnoid, and then the pia mater is the closest in. Our spinal cord itself. The right side of this picture is talking about the somatic part, all going to your motor system. The left side is your autonomic part. Again, nervous system has to do the autonomic part, parasympathetic, sympathetic, and the motor system as well. And this just, again, review of breakdown of our systems. This is a good review slide, especially for pharm, when it comes to like different drugs, where they have their effect with regards to like the vessels, is it the glands, cardiac muscle, what is happening where. Remember the big thing also is that with parasympathetic, they have a very long preganglionic, short postganglionic. Your sympathetic system has a very short preganglionic, but a long postganglionic neuron. Why does the sympathetic system has a short pre? Because it's got to go with that sympathetic side chain ganglion that rides right along the spinal cord. It goes there first, synapses, and then goes off. Okay, so let's get through some motor neuron diseases. The first one is amyotrophic lateral sclerosis, ALS for short, also known as Lou Gehrig's disease. The most common form of motor neuron disease, most commonly between the ages of 40 and 60. If you ever watched that movie about Stephen Hawking, he also had ALS as well. And you could see him as a young man, and then later on he started getting some muscle problems, like he couldn't hold a cup anymore, and it progresses from there. It's a mixed upper and lower motor neuron disease. So that is very important to know that it is mixed, upper and lower. And limb and the bulbar. So the cortical bulbar, is that motor or sensory? Look at the direction of the word. Cortico is the cortex. Bulbar is the second word, meaning it's going towards that. So this is motor or sensory? Motor. The sensory ones are called spinothalamic because they start in the spine and they go to the thalamus in the brain. So you see the direction of the word tells you, is this a sensory or is it motor? Corticospinal is another one we'll learn about. Corticospinal tracts. Cortex of the spine. Motor. So the throat muscles, they have problems with breathing and swallowing because they can't use those muscles anymore. So they have to go on feeding tubes. Respiration to protect the airway because they can't do it on their own anymore because their muscles don't work. Initial complaints are just muscle weakness. They're often bilateral and symmetrical. So both hands will stop working or having deficiencies together around the same time. It's not going to be unilateral. Again, if it's a bulbar involvement, swallowing, chewing, speaking, breathing. If you watch the new Joker movie that came out, he had a cortical bulbar affect, which made him laugh. It's a real disease. Like, people, they can't uncontrollable laughter in the most obviously worst times to start laughing, but it happens, and that's what his thing was. Extraocular muscles and sphincters are spared. So what does that mean? They can control, they don't have any loss of bowel function. They can still control the sphincter. They can still control when they go to the bathroom. Extraocular muscles are still okay, so they can still move their eyes. How did Stephen Hawking communicate? With his eyes looking at different parts of the screen, and that way able to make the words. Amyotrophic, muscle wasting from lower motor neuron. That's the amyotrophic part. So what happens is, basically, the nerve, with all those 200 units that all innervate all those little individual muscle fibers, starts to atrophy and pull away from the muscle. Once that nerve atrophies and pulls away from the muscle, there's no more communication from the nerve to the muscle. Will the muscle work? Nope. That's what ALS is. The nerve pulls away and atrophies. So the amyotrophic is talking about the lower motor part. The lateral sclerosis is referring to the area where the upper motor neuron and the lower motor neuron synapse. Remember, they have to connect. So you have an outlet on the ground. If I blew up that outlet, the upper motor neuron won't work and the lower won't work as well. You get a mixed problem. That's what the lateral sclerosis is referring to. Where the junction occurs, you get a problem. So again, here's a picture. You can see here this axon is getting thinner and it's starting to pull away. Eventually, it'll de-innervate or denervate the muscle and pull away. Progressive disease, usually fatal within 3 to 5 years. Death results from pulmonary infection or respiratory failure. Why? They can't breathe very well. They need help supporting their airway. They're probably going to be ventilated. You have risk of developing infections with that. Frequently begins in the hands, feet, so it's a distal and works its way proximal in. As the disease advances, muscle will become progressively weaker, and then eventually chewing, speaking, swallowing is all a problem. Again, doesn't affect bladder or bowel or the senses. Okay, Stephen Hawking was still publishing and writing things while he was in the wheelchair, couldn't do anything. But he was still, his brain was still working, the cognition was normal. It's just a problem with the motor system not working. So pathophysiology for this one, degeneration of motor neurons, either in the primary cortex affecting the upper motor neurons or in those anterolateral horn where the synapse occurs, where you start affecting that lower motor neuron. Neurons can demonstrate this cytoskeletal disease. Too many intermediate filaments in the cell bodies and axons. So we're talking about the actual neurons now itself. These intermediate filaments normally provide structure, but with ALS, we destroy those things. Very little inflammation is noted with this. It's just a degeneration disease, takes it away. So possible causes, glutamate. So remember, it's an excitatory neurotransmitter. So if you don't clear it fast enough, that stimulation will continue going on. You continue to stimulate because that glutamate's still there. So if you have too much glutamate, you overstimulate the neuron and you can cause cell death and motor damage to that neuron due to overexcitability. There's also hereditary cause. About 5 to 20% of cases do have some familial component as well to ALS. So clinical manifestations, increasing weakness in one limb, they'll progress to the other side as well. Usually in the hand, walking becomes a problem, clumsiness, they'll drop things. Fasciculations, muscle cramps and twitching in the arms, shoulder, and tongue. Fasciculations are usually due to an upper motor neuron disease. muscle stiffness, spasticity, and impaired speech, swallowing issues, and difficulty with posture. A lot of the things with a lot of these neuro diseases is just the treatment is just taking care of the symptoms. If they're having cramps from the spasticity, you can give baclofen, a different drug, to help with the cramps, so on and so forth. You're just really just treating the symptoms at this point for that patient. Complications of ALS, breathing is going to be the biggest one in eating because they can't use the muscles of the throat. They're going to have problems with supporting their airway, may need a tracheostomy and respiration permanently. Alternate forms of communication. So when you're dealing with patients, and this is not going to be on your exam, but this is just dealing with patient education. Yeah, it's great that you like diagnose them and you found the right disease, but if you're not taking care of what's going to happen when they leave the hospital or leave your office, you're missing half of it right there. You know they're going to have problems with speech later on. Start thinking about different forms of communication when that becomes an issue. Eating difficulties, they can't swallow because the muscles don't work. They're at risk for obviously aspiration pneumonia now because they can't swallow right. Some of the contents may go down the lungs, causing that issue. They may have some frontotemporal dementia may occur, so decision making. That's where the frontal part is all decision making, stuff like that. So again, you can see how the nerve is just pulling away. And late stage, there's no nerve there at all, totally atrophied and went away. So that's what ALS is. Parkinson's disease, clinical symptoms, TRAP. Remember that mnemonic, I put it in red for that reason. Tremor, rigidity, akinesia, and postural instability. Those are the 4 major symptoms presenting with Parkinson's disease. May have some cognition problems, sleep issues, speech. 1 to 2 people will get it. And it's a defect in dopamine is the problem. What can cause Parkinson's to occur? Obviously, these are all different things. Obviously, it's exposure to certain chemicals. Some drugs may also do it as well. Repeated head trauma. So Muhammad Ali, the boxer, many, many years of boxing, he developed Parkinson's later on in life, obviously due to all the trauma from boxing. Michael J. Fox, you guys know who he is? They made a movie in a while, but he was popular in the 80s and 90s. He has Parkinson's, and the interesting thing about his Parkinson's is that he was on a movie set way back years ago. I don't know what movie it was or whatever. But on that set, there was like 5 people all got Parkinson's later in life. And they traced it back, so there must have been some sort of exposure on that set because like 5 people from that one movie set all got Parkinson's now. So these are the different causes that could present with Parkinson's. Pathogenesis, so we just basically, it's selective destruction of the dopamine cells in the brainstem and the basal ganglia, especially of that substantia nigra. So it's substantia nigra because it's black, because dopamine turns it black. On autopsy, obviously you can't do this while they're living, but on autopsy you can slice that substantia nigra and that blackness is gone, or it's really reduced because there's less dopamine in the area. Lewy bodies is the hallmark of Parkinson's disease, these Lewy bodies. There's these sticky white protein that get stuck in these patients that have Parkinson's. Alpha-synuclein is a protein that's in all nerve cells, and it makes up a good portion of these Lewy bodies. But they think there's a genetic defect with your alpha-synuclein that kind of makes it go haywire. And that's where these Lewy bodies start to collect this alpha-synuclein inside the cell. So you can see here, in a normal, intact individual, plenty of dopamine released to cause its effect for your coordinated movement. But in a patient with Parkinson's, they have less dopamine for the neurotransmitter, so less effect, and they're going to cause some movement disorders later on. Okay. Just paying attention or not. Okay. Um, Again, here's that substantia nigra. You can see how dark it is up top, and on the bottom, it's a lot reduced because there's less dopamine there. So let's talk about this alpha-synuclein and these other proteins that are here with regards to Parkinson's. So there's 3 normal molecules that are involved in apoptosis. Is apoptosis bad? No, just cell needs to die, we replace them, it's normal. When you have a defective Parkin gene, cell death does not occur. So the Parkin gene is defective, Parkinson's. The Parkin gene, so we get a disturbance in protein degradation. We can't degrade the alpha-synuclein, so it starts to accumulate as these Lewy bodies, causing deposits of fibrous tissue. What should you remember whenever you see fibrous tissue? Bad stuff. It's not going to function as well as it would normally when you have this fibrous tissue. So these dopamine terminals are reduced, less dopamine being released into the synaptic cleft. We have another protein called ubiquitin. And ubiquitin marks proteins for degradation. So again, we want to degrade the proteins, program cell death, apoptosis. But we have a issue with ubiquitin. So yeah, we're trying to mark these proteins for death, but the ubiquitin doesn't work. So these cells don't die appropriately and they start to accumulate. Beta amyloid will also start building up in the presence of the buildup of synuclein. Beta amyloid is a known factor in Alzheimer's disease, and this beta amyloid may be the link between Alzheimer's and Parkinson's. Because the people who have Parkinson's sometimes develop Alzheimer's disease and symptoms. People with Alzheimer's sometimes develop Parkinson's afterwards. So they think the link is this beta amyloid is what causes the link. And obviously we have oxidative stress. Whenever we have oxidative stress, we know that's not good. It causes neurodegeneration in this case. So, I got it backwards here. Okay, so summary. Parkin allows for the abnormal overgrowth of these Lewy bodies. Beta amyloid increases the alpha-synuclein, adding to the accumulation of these Lewy bodies. We don't like them. Overproduction of this alpha-synuclein accumulates as these Lewy bodies. They keep building up. We can't mark it for destruction, so they keep building up. No protein degradation because the ubiquitin is not working. So I think it's telling this protein to be destroyed. And all these Lewy bodies eventually will start to destroy the dopamine. So there is a form of dementia that's called Lewy body dementia, or LBD. One of the big signs of Lewy body dementia is hallucinations, which is different from other forms of dementia. Lewy body dementia will have hallucinations. That's what Robin Williams had. And you can see here, these are these Lewy bodies, little inclusions in the cell body that shouldn't be there. And they cause all these issues. So that's it right there. So that's what a Lewy body is. Buildup of protein due to defective genes that don't mark it for destruction, and it starts building up. So decreased motor function. So there's 2 ways that we have issues with movement and dopamine. One is the direct pathway, and the other one is an indirect pathway. The direct pathway is going to excite the motor cortex. So if you stimulate the direct pathway, you'll stimulate your motor cortex, and you can do your coordinated movements. Walk into a wall, turn around, and come back. Those are coordinated movements, tandem walking, all those things that you're testing is making sure that the basal ganglia and all that stuff is working. In the indirect pathway, if you stimulate the indirect pathway, you're going to inhibit movement. Okay, so in a normal function, we have substantia nigra that produces dopamine, and that's going to activate the direct pathway to promote motor activity, and it's going to suppress the indirect activity, the motor inhibition, so that we have great fluid movement. This is what normally happens. We activate the direct, we inhibit the indirect. So we have good coordinated movements. When you have Parkinson's, things change. We have no dopamine being produced, therefore we're not activating the direct, and we're not inhibiting the indirect one. So who's going to win, the indirect or the direct pathway? The indirect is going to win, and we have reduction in movement because the indirect pathway is not being suppressed by dopamine, so you have uncoordinated movements due to inhibition of your motor cortex. They're not going to be fluid, they're going to be very jerky, bouncing around, and so forth. Symptoms of Parkinson's typically appear when 70 to 80% of your dopamine is gone, just like in the kidneys. We need like 75% of this tissue to be destroyed before you start seeing damage. Same thing here. So rigidity, lead pipe rigidity. So when you do passive range of motion, you take their arm and you tell it to go down, and they go nice and smooth, and they do all this. With rigidity, it's going to be like click. You're going to try and move it down, and there's a gear there. It's like hitting a gear every time and getting stuck, like a cogwheel in a clock. That's what this is going on here. Rigidity of the trunk, gait and postural abnormalities. So they're going to be hunched over and stooped over. Shuffling, hasty gait. So instead of like a normal walk, they're going to shuffle. Or feel like they're walking faster, but they're not. They just can't coordinate their movements. So that is what you would see in a patient with Parkinson's. Writing gets very bad. They have micrographia where they'll write really small. They get a resting tremor that stops with voluntary movement. So we said before we had an intention tremor where you do finger to nose, and as they get closer, it shakes. With Parkinson's, it gets better with voluntary movement. So you say, touch my hand, and the tremor will go away. With purposeful movement, the tremor goes away in Parkinson's. Hand tremors, pill rolling, they'll have their hands, and they'll start doing this, like they're rolling a pill in their hand. That's another form of an abnormal movement due to Parkinson's. Let's sit there and do this. Akinesia, bradykinesia, they're having trouble to start movements or to slow down. Expressionless face, it's called masked faces. There's no expression in the face. Loss of postural reflexes, so they're hunched over. Loss of arm swing during walking. When people normally walk, there's a normal swing to their arms, but with Parkinson's, they're straight down. They're also going to probably have a wider base when they walk or stand, so they have more balance. They can't balance with their feet together. Turning on block. So you tell the patient, hey, walk into the wall and turn around and come back. So that's a normal response. In Parkinson's, they can't do that. They'll go to the wall and they'll shuffle their feet like this, and they'll turn around and they'll start walking again. That's called turn on block. They can't do a coordinated movement of turning around. They have to do it that way. And here's a little summary slide for Parkinson's. And again, here's Muhammad Ali and Michael J. Fox. Okay. No? Aren't you guys this whole Dr. stuff grew up on that stuff? That's old for you? Okay, I don't know. I lose it. Okay, we'll stop here. We'll finish this up Thursday. Hello.
So I just wanted to ask a quick question. You mentioned the extrapyramidal movements with the medication. Does that include like tardive dyskinesia or
Yeah. Mm-hmm. Okay, so let's finish up neuro. Your exam's on Monday. I know you guys got micro tomorrow, but we'll finish this up. So there are three major autoimmune disorders we're going to go over. The first one is multiple sclerosis. With multiple sclerosis, the key thing with this one is it's a disorder of let that come. So multiple sclerosis is a disorder of space and time. So what does that mean? Space. Where is these lesions going to be forming in the brain or in the spinal cord? What level where these lesions form is where they're going to have their deficits. Time. With multiple sclerosis, they have relapses and remissions. So they're going to be fine for a while, and then a new plaque will form. And when that new plaque forms, they get a new symptom. So that's what's going on there. So they get exacerbations and remissions. It's an autoimmune disease. Etiology unknown as far as what causes MS, maybe genetics, environment, or a virus may be the underlying cause for it. Very common in these northern European countries or people from northern European descent. In US, more women than men do get MS. So again, if a question has a female and they start getting some numbness and tingling or double vision, off balance, certain questions, but it's a young, 30, 40-year-old woman, might be MS because more women than men. And again, there's the age, 30 to 40. So that fourth and fifth decade of life is when they start getting diagnosed. So symptoms vary from person to person because it all depends on where these lesions form. If these lesions form in C4, C5, that area, you're going to have issues in C4, C5 going out of the root. If it's more in the brain, you're going to have problems wherever the homunculus, those issues form. That's where you'll have your issues. Again, this is a central nervous system problem with MS, so it's only the brain and the spinal cord. Attacks can last days, weeks, or even months. And again, they have these remission phases where they'll be fine for a while, they won't be symptomatic, and then they have a flare-up. There are some triggers for these flare-ups: fever, hot bath, sun exposure, stress. Again, it is common for these relapses to occur. As the disease progresses, the relapses become more frequent, and they'll get worse. So what's going on? It's an autoimmune attack on the myelin sheath in the CNS. That's what MS is. It just degrades the myelin sheath. So what is the purpose of the myelin sheath? Signal transduction, so it goes fast and goes through the whole entire way, all the way down to the end of the wire. When you lose the insulation, it's like on your, when you plug in your charger to the wall and the end of it gets crinkled and suddenly you see the wires exposed and it doesn't charge anymore. That's what MS is. It just, you lose the layering that surrounds it and insulates the wire, and now it doesn't work as well anymore, and wherever that wire is damaged, that's where you're going to have your issues. That causes so maybe trigger a virus, and then it may be a response to a specific protein that got into the CNS that causes this whole autoimmune cascade to start. You get inflammation of the neurons in the CNS. That leads to plaque formation. So you're going to see a lot of plaques on scan with MS, followed by scarring, and that's called gliosis. So you have scarring in the brain, it's called gliosis. Selective loss of the myelin, again, throughout the length of the neuron. Plaques can accumulate in the brain and the spinal cord, particularly in the optic area. So they get vision problems with MS. Some double vision, one of the big causes, symptoms. Neuronal bodies may be spared, but the axons will degenerate. and that's what sends the signal down the whole way. So if the axon starts to degenerate, the signal is not going to be as strong, and you're going to get very weak contractions later on. Injury is focal in nature. They're going to have problems. Okay, my right hand is not strong anymore. My left leg is whatever it is. They're going to be, it's not going to be like, oh, I'm just numb, my leg is numb everywhere. No, it's going to be a specific part that is being affected by the MS. And obviously, demyelination is total within a plaque. It's not going to do anything anymore. So the clinical manifestations for multiple sclerosis, what are they going to present with? Again, each exacerbation of MS is a new demyelinated plaque. That's why I say time and space, just like Dune. Wherever they have a flare-up, it's a new lesion in a new part of the spinal cord of the brain. Musculoskeletal issues, loss of balance, muscle spasms, numbness or abnormal sensation in any area. Why is it vague? Again, because it could be any area. We don't know. It just depends on where the plaque forms with these MS patients. They may have some problem with coordination, making small movements. Tremor is a big one with MS patients. They may have a tremor as well. Vision problems, double vision, okay? Monocular vision loss, so just one eye has lost vision, not the other one. So one eye vision loss, or even eye discomfort, eye pain, okay? So these are the symptoms they may present with. It's a very mixed bag, but through your history, and obviously on a question on your exam, I'd have to give more information leading you to, yes, this is MS versus the other ones. Fatigue, depression, dizziness may come as well. So again, vary depending on the presentation of the patient. Here's a good review summary slide going over the different symptoms that people may present with due to the multiple sclerosis. The next one is Guillain-Barré syndrome. This you hear a lot about with flu vaccines, one of the side effects. Very, very, very rare occurrence, but it does happen. You can see 1 to 4 cases per 100,000 annually. It is autoimmune. So Guillain-Barré has a couple of names associated with it: GBS, Guillain-Barré syndrome, or acute idiopathic polyneuropathy. GBS is MS just in the periphery. It's the same process, demyelination, but this time it's the peripheral nerves. Whereas MS was just the brain and spinal cord, now we're dealing with the rest of the peripheral nervous system. Usually 40 to 50 years old, occurs with or without sensory disturbance. So Guillain-Barré, they may not have any sensory issues, but they can't move their legs. But you do your whole assessment, the light, touch, and pain. Do you feel sharp or dull? Light touch, proprioception, that will all be normal with a Guillain-Barré patient. Was implicated with vaccine administration, so obviously they have to ask you all the time now, if you had a flu vaccine in the past, were you okay with it, and stuff like that, to make sure you didn't have any issue with GBS afterwards. Swine flu had some, H1N1 a slight increased risk, no association with the meningococcal vaccine, and other type of rabies vaccines have been implicated as a trigger, but no one gets the rabies vaccine unless you've been bit by something that has rabies, and 2, you want that rabies vaccine or you're going to die anyway, so just get it. The GBS is self-limiting, it'll go away. We'll learn about that in a minute, but it's self-limiting, it goes away. There are 3 main types of GBS. The main one, the most common one, is the acute inflammatory demyelinating polyneuropathy. Yes, that's a lot of big words, but just break it down. Acute means it's happening now. Inflammatory, we know the nerves are being inflamed by this process that's going on. This autoimmune attack on the nerves is causing the inflammation. Demyelinating, because we know the myelin is being ripped off due to the autoimmune process. And polyneuropathy, because it affects multiple nerves. So yes, they're big words, but they're not that bad when you break it down. The other one is an axonal, where it has motor and some motor sensory involvement as well. And the last one is just Miller-Fisher. So again, just know the first one, the most common one that's there. Usually going to be after a stimulus event, some triggering event is going to cause GBS to happen. It doesn't happen spontaneously. There usually is some sort of event that happens beforehand. Campylobacter jejuni also is involved, so your micro stuff. Have you gotten to the Campylobacter yet? All the GI bugs? Okay, that's probably the next one. But you'll get to that one. So Campylobacter and some other ones, pneumonia, flu, EBV, HIV can cause it as well. So again, autoimmune on the PNS. Multiple sclerosis is autoimmune on the CNS. Campylobacter jejuni expresses lipooligosaccharides. These are gangliosides. These gangliosides have antibodies produced by the body, and they are the ones that attack and destroy the myelin. So it's these gangliosides that cause the issue. The basis for the flaccid paralysis or weakness is conduction block. The impulse can't get past the nerve. So if the brain doesn't sense the impulse, you're not sensing anything from the outside environment. If the motor system is damaged from top to bottom, you're going to try and tell your leg to move, but it won't move because the conduction can't get down to your leg to move it. So what that means is that axonal connections remain intact. Because the axon is still intact, it's just the covering that's damaged. Recovery is possible because the nerve is still intact. And as long as remyelination occurs, they'll be okay. In severe cases, they do get some secondary axonal degeneration problems. And in those cases, because now the actual axon, the actual nerve is damaged, recovery is very, very slow because it takes a long time for those nerves to recover. So clinical manifestations begins, and I put it in red because it's important to know for GBS. Bilateral, so both feet will be affected at the same time, or hands. Symmetrical, so again, same side of the body. Ascending, so it starts at the feet and it works its way up. Weakness or paralysis. So bilateral ascending paralysis is GBS. Starts at the feet, then it goes up to your calves, then your knee, then your thigh, and then your hips, and it works its way up, the ascending paralysis. There are other diseases we're going to learn later that have a descending paralysis, so that's why it's important to know the differences. So GBS is an ascending paralysis. They have some like rubbery legs, feel like they can't get their feet under them. Evolves over a few hours to days. Legs are more affected than the arms are. 10 to 30 require mechanical ventilation because they can't support their airway anymore. Okay, if it affects the motor system for respiration muscles, they can't support their airway, they need to be intubated. They may have some pain with movement. Reflexes are diminished or absent because the myelin that covers the nerve that's going to send the impulse to the muscle to flex during the reflex arc may be damaged, and that's why you may have some diminished reflexes. Autonomic nervous system issues. We talked about this before. Cardiac dysrhythmias, BP instability, so the blood pressure is going to drop. They have hypotension, orthostatic hypotension. Paralytic ileus, the bowels don't move very well. So stool gets stuck, get constipated. Orthostasis, that's getting up too fast, getting lightheaded from dizziness and urinary retention. Diabetics also get this as well. Long-term untreated diabetics will have autonomic dysfunction as well. But GBS patients will have it as well, and those are the symptoms. 50% of people will have some facial nerve palsy, weakness. Lower cranial nerve involvement can also occur with the bulbar around the mouth, weakness. And they can't manage their secretions, they can't manage their airway, so they may need to be intubated while they're recovering from the GBS. And here's another good summary slide to review for your GBS. Myasthenia gravis is the last autoimmune disorder we're going to cover. We went over this this a little bit yesterday when we talked about that neuromuscular junction. So myasthenia gravis affects neuromuscular transmission at the neuromuscular junction. And what happens is, remember, we talked about yesterday, the myasthenia gravis occupies the receptors for acetylcholine on the postsynaptic membrane. And by sitting there, it blocks the conduction of acetylcholine. It has no effect on the muscle. Therefore, you can become very, very weak, and eventually you'll lose your strength. So the hallmark for myasthenia gravis: decreased muscle strength with activity that returns after rest. What we do is we have them do a hand grip strength. We have them squeeze, and we see how much strength they can produce with their hand. And we have them repeat it. And over time, that squeeze is going to get weaker and weaker and weaker because there's less acetylcholine stimulating the muscle cell to squeeze, to do anything, because we don't have that much acetylcholine to occupy the receptors because myasthenia gravis has blocked them all. So once they rest, the receptors become free again, able to be stimulated one more time. After they rest for a little bit, you give them another hand grip strength, and the strength returns back to normal. But then it will fatigue out again as it goes on. So fluctuating periods of muscle fatigue and weakness that improves after a rest. If they have myasthenia gravis, there's usually a high percentage they're going to have other autoimmune disease, hyperthyroidism like Graves' disease, rheumatoid arthritis, lupus, and polymyositis. 30% will have a maternal relative with an autoimmune disease. So next year in the summer, you guys will take a genetics course, and you'll go through the pedigree and all that stuff, and know where you'll do all that stuff in the summer. Etiology unknown. We don't know what causes it or what triggers it. Onset is often insidious, meaning they don't know it's coming on until it already happens. Can affect any muscle, but the ocular muscles are frequently affected. So if you can't hold your eyelid up anymore, what's that called where it lags? Ptosis. So they're going to present with ptosis, lid lag, because the ocular muscles are affected. They can't keep the eyelid up, and they present with ptosis. And then severe causes can involve the diaphragm and intercostal muscles as well. So now we're problems with what? Breathing as well. So pathology, muscle end plate, that post-terminal, shallow, abnormally wide, or absent synaptic clefts. But the presynaptic side is normal. This is a postsynaptic side problem. You get lymphocytes that present at the motor end plate. IgG and C3 complement are there. And they also affect that postsynaptic membrane so that ACH can't bind to anything. Remember, myasthenia gravis attacks the acetylcholine receptors on the muscle end plate. So we have our normal neuromuscular junction at the bottom here. Remember, it's muscle, so it's nicotinic receptors for acetylcholine. And now look at the myasthenia gravis one. Now we have these antibodies against the nicotinic receptor. And it's going to attack those receptors so that they cannot bind to ACH anymore. If they don't bind to ACH, the muscle can't contract as well. That's why you get the fatigue, the weakness, because there aren't enough receptors for you to generate enough of a response. Remember, those one nerve will up to like 200 muscle fibers. It'll stimulate. Well, out of those 200, now you took out 100 of them because myasthenia gravis wiped them out. So you have less motor fibers that you're stimulating, and that's where the fatigue comes in. Eventually, you can't move them at all. So again, autoimmune, decreased response to acetylcholine on the postsynaptic membrane. Therefore, we reduce the number of receptors available. Now, what is present in that synaptic cleft that's going to help with the recirculation or recycling of acetylcholine? Acetylcholinesterase, right? And what does that do? It breaks down acetylcholine and stops the activity from happening. So in these myasthenia gravis patients, that acetylcholinesterase is still working normally like it normally should. So now let's look at it now. Now we have myasthenia gravis antibodies blocking the acetylcholine receptors, but we also have acetylcholinesterase working to degrade the acetylcholine. So you're going to have less of an effect of that acetylcholine because it's still being broken down in the cleft and there's less receptors to be active to it. So one of the drugs we give is a drug that blocks acetylcholinesterase. What's that going to do to the acetylcholine in that cleft? Let it stick around longer. And as it sticks around longer, it has more of a chance to bind to a receptor to give some sort of benefit to strength. So the drug we give blocks the acetylcholinesterase from breaking down the acetylcholine so it sticks around and has more of an effect. Continues to block the acetylcholine binding and receptor activation, and we already discussed all that. So if they lack autoantibodies to the acetylcholinesterase receptors, they have autoantibodies against another type of receptor. So if you have a patient who looks like and they appear like they have myasthenia gravis, you do your test. Yes, they have it. You do your blood test to see if they have the antibodies. They don't have any antibodies to myasthenia gravis. They don't have any antibodies to that acetylcholine receptor. There must be another thing going on. So that's what this is talking about, this MuSK. It's a muscle-specific receptor tyrosine kinase. But basically, it also helps with acetylcholine uptake having an effect so that if you have a patient who presents like they have myasthenia gravis, but they don't have the receptor antibodies with like an autoimmune disorder, all autoimmune disorders are going to have some sort of antibody or autoantibody floating around their body that you can find. If they don't have it, they might have this other one called MuSK. It's just another way of with those receptors. And again, same thing we talked about, just another way of drawing it. Now, normally, in a normal situation, repeated stimuli of the motor nerve, the amount of acetylcholine released from the nerve terminal declines with each stimuli. Usually it's not a problem as we have enough receptors in the area to accommodate the lingering acetylcholine to have an effect. However, with myasthenia gravis, there's a decrease in the number of functioning receptors. We blocked them out because of the autoantibody is blocking the receptors and they're not functioning anymore. So we get a decreased action potential during repetitive stimulation. There's not enough to stimulate anymore really to get you over threshold. So you get progressive muscle weakness. They get progressively weaker with repetitive stimulation. Yes? So downregulation, yes, it can be considered downregulation. You are losing the number of receptors. The difference is like when you talk about like diabetes causing downregulation, it's usually due to oversuppression, where they get burnt out and they start dying off. This is mainly due you're just destroying the receptor itself. So it's not necessarily, it is, yes, are we downregulating, but it's not like a normal process. It's just being destroyed. So again, here's your ptosis. Diplopia is usually the first symptom. Again, those extraocular muscles. Eyes can't move to focus on an object. Ptosis, difficulties with facial expression, chewing, swallowing, talking. No sensory or pain components. This is purely muscular. So myasthenia gravis is purely motor. So with these nerve problems, whenever we mention what type or sensory or motor they're going to affect, make sure you note that because certain ones will only affect motor, some are sensory, some are both, some are only sensory. Is this you guys, your generation? Okay, epilepsy and seizures. So when we get to seizures and epilepsy, When you guys learn about the heart, when they're about PVCs, how one little area of the heart gets excited, sends off a signal, the whole heart discharges and goes. That's what seizures are, epilepsy. One part of the brain gets irritated, starts discharging signals, and the brain goes haywire. So again, paroxysmal disturbances in cerebral function cause abnormal synchronous discharge of cortical neurons. So those neurons just start discharging by themselves, cause all this crazy activity, and your body goes haywire during it. 0.6% of people in the US have recurrent seizures, which is epilepsy. So if you have one episode of a seizure, you do not have epilepsy. Epilepsy is recurrent seizures. Then it's epilepsy. If you just had one seizure, you don't have epilepsy. 2/3 of new cases occur in children. I'll talk about that in a minute. So, etiology of seizures, 75% are idiopathic. They just happen. We don't know why. There may be some sort of genetic basis. So if someone comes in with a seizure, ask if anyone in their family also has seizures. Secondary causes, brain injury, stroke, trauma, mass lesions. So any type of lesion in the brain, mass effect causing the contents of the brain to shift because you have a lesion there that's occupying space. That compresses the brain. It will send signals. It can cause seizures. Metabolic causes can also cause seizures as well. Low blood sugar can cause you to have like a seizure-like activity. Fevers can cause seizures as well, especially in kids. So we classify seizures based off of the symptoms they're having and the physiological, what's going on with the brain. We have two types. We have partial and we have generalized. The key thing, loss of consciousness. People with a generalized seizure will have full loss of consciousness. Partial focal seizures will either have no loss of consciousness or abnormal level of consciousness. They'll be like kind of confused, twilight, not acting normally, a little bit confused. So partial focal seizures, they do not lose consciousness. Generalized seizures do lose consciousness. Now, the other key thing, partial focal seizures are one-sided. Only one side of your brain is having all these electrical discharges. In a generalized seizure, when you have full loss of consciousness, both hemispheres, both sides of the brain are being affected by these abnormal discharges. So as we go through these seizures, you'll see some lose consciousness, some have abnormal, some don't. And that kind of helps you from there. So again, partial seizures stay on one side of the brain. A partial seizure can also generalize secondarily, where it jumps to the other side of the brain. So, caused by focal brain diseases. So look for an underlying cause with these patients. That's why they're one-sided. A simple partial seizure begins with motor, sensory, or autonomic symptoms. Depends on the location of the seizure focus, where it is, what symptoms they're going to have. Consciousness is often preserved. If they do start off as a simple seizure and then devolve into like a tonic-clonic seizure, that means there was secondary generalization where it spread from one side of the brain to the other. Both sides have to be affected if you're going to have loss of consciousness. So some examples that can happen, we can have some somatosensory issues, they'll have some tingling go on, focal motor issues, those tonic-clonic movements of the upper lip can also be there. Grimacing is one of these simple partial seizures. It could be that is all you'll see is a grimacing. Some autonomic issues, so some sweating, flushing, pallor. Visual disturbances, maybe some visual hallucinations, if that is where the focus is starting from. So if you are having some visual hallucinations or seeing things, that may be in their visual, maybe in the back of the brain is where they're having their issues. If they're hallucinating that they're hearing things, maybe it's the auditory cortex in the temporal area of the brain that's causing them to have these issues. Some other ones, they'll start smelling weird things. So maybe in the olfactory center, that's where they're having the issues. This down here is an EEG. Don't be scared with your EKGs, but they're measuring the same exact thing, the electrical activity wherever they put the little probes. So if you ever seen someone get an EEG, they have a little cap that they wear that has probes over the entire head, and it measures all parts of the brain. And that's what this is all doing here. These are all different parts of the brain, and they want to see where this activity is coming from. So if they see the brain waves are acting up here, going crazy, and then spreads to the other parts of the brain, they know that wherever that location was, that is where these seizures are originating from. So it's a way to figure out what part of the brain is having this discharge focus. Do we need to be worried about brain lesions, anything else going on with that patient? So that's what an EEG is. You will not have to analyze an EEG, ever, unless you go to neurology, then you maybe. But usually the neurologist will do all that. Complex partial seizure. So we're still on a partial seizure. It's still one-sided, but with these complex ones, they have an aura. They may feel something coming on with it. But again, starts in one area of the brain and spreads in that one localized area. They may get some abnormal sensations, sensation of deja vu, where they feel like they've already done this thing before, like these sensations are coming on. These things could be, underlying, like the calm before the storm, before the seizure comes on. So this is your complex partial seizure. Again, hallucinations, impairment of consciousness. They're not total consciousness, but they have an impaired level of consciousness. You can see this is a left temporal lobe seizure. That's that activity there. Temporal lobe, what's in the temporal lobe? Hearing. That's when they're hearing some auditory hallucinations. Here's your olfactory hallucination. You feel like you're smelling skunks. You guys know George Gershwin? He composed a lot of famous classical piano pieces. You've heard them if you play. You heard it. You know this guys. But he had a tumor in the brain, and he thought he was smelling rubber all the time, like burning rubber. But it wasn't there. It was just the hallucination from the tumor in the brain causing those things to happen. So complex partial, they'll have an aura, some abnormal level of consciousness. Absence seizure. Now we're moving on to our generalized seizure. Some of you may have absence seizures, or absence if you're French. It goes both ways. Dr. Wood does it absence, but it doesn't matter. But what is an absence seizure? Usually in childhood, maybe in adulthood. Usually remit by then. But basically, it's daydreaming. You're staring off into space for like 10 seconds, and then you just come to and you're fine. But for those 10 seconds, you are oblivious to the world. You are just off into space staring, and then you snap back into it. That is a absence seizure, also known as daydreaming. They may have some eyelid blinking during it, some slight head movements, but basically nothing's really going on. But the patient is fully alert after the seizure. Okay? Can impair school performance. When you guys start learning about peds in the winter, one of the questions you have to ask all your peds patients is, how are you doing in school? Talk to the parents, how are they doing in school? Do the teachers say anything? Because that's where you'll find out if, the teachers will say, they just stare off into space sometimes for like 10, 15 seconds and they snap back. That might be having an absence seizure. There's nothing wrong. They give them some medicine and the seizures go away. But again, it can impair school performance. So whenever they start dropping school grades, is it their eyes? Are they not being able to see the board? What's going on? So talk to the parents, see what's going on. There may be some dominant trait here. So again, with these seizures, always ask about any family history of any seizures. We're in the generalized, so these people do have loss of consciousness. Your tonic-clonic seizure, this is your grand mal seizure. This is the one you see dramatized on TV. They don't flail like that. In real life, when they're having a seizure, it's a little bit different. But sudden loss of consciousness, so they're totally out. Then they have rapid tonic muscle contraction, leg extension, they tonic, they're totally frozen, they squeeze everything, and then they relax. That's the clonic phase, and then they relax. So the tonic phase can last 10 to 30 seconds. Then the clonic phase of limb jerking, of that happening, then they may go back and forth. Builds in frequency, and then gradually subsides. Patient will remain unconscious for several minutes. Now, this phase, when they wake up after a seizure, is called the post-ictal phase. So after they have a seizure, they're in this post-ictal phase. It is a period of confusion. Now, in cardio, you guys have learned about syncope and causes for syncope, right? So, what is syncope? Loss of consciousness, right? You pass out. What's a seizure? Loss of consciousness. You pass out. Now, if they come to the hospital afterwards and said, oh yeah, we found them that they were down, they were unconscious when I found them. They weren't moving or anything, but they came to and I brought them to the hospital. How do you know if this is a seizure versus a syncope event? When they wake up, the post-ictal phase, they're going to be confused. If it was a cardiac cause for the syncope, they will not be confused when they wake up. They'll be fine. Seizures, they'll be confused. Other symptoms, which I think I have later on, but we'll talk about it now. So here's the grand mal seizure, the tonic and the clonic phase. They're going to be very sore. Their muscles are going to be hurt and very sore and tender after a tonic-clonic seizure. They will not be sore and tender after a syncopal event. But with a seizure, because of the tonic-clonic activity, the muscle contraction and everything, they may have some muscle soreness. Another thing that happens with seizures causing loss of consciousness is they'll lose bladder and bowel function. So when they wake up, they'll soil themselves, or during the event they've soiled themselves. In a cardiac event, they won't do that. So you see here with the tonic-clonic, the generalized, it's in the middle and spreads to both sides. So both sides of the brain are affected. That's why they pass out, loss of consciousness. So here's a way to study these things. We have our generalized seizures. We know that these do have loss of consciousness. We have our focal, which doesn't have very much local loss of consciousness. But these ones, they evolve. That secondary generalization where it will spread from one side, just the electrical activity to spread to the other side of the brain. There is no discharge focus on the other side. It's just the electrical activity went to the other side of the brain. So absence seizure, tonic-clonic are the ones that we went over today. And focal, again, remains aware. But when it gets to this side, this is your secondary generalization. It's going to spread to the other side of the brain, causing abnormal level of consciousness. We're still under the focal cause, not the generalized. So just know the ones that we went over. So regardless of whatever the seizure causes, what happens during a seizure is pretty much the same. All these neurons are activated synchronously. We get disruption of our normal inhibitory effects, so disruption of GABA, our voltage-gated calcium-dependent channels, and those get messed up. And this allows for the development of the seizure. So the inhibitory effects, things that are supposed to calm the brain down to prevent these seizure activities, they have a problem with GABA. Remember, that's our major inhibitory neurotransmitter. They're going to have issues with it. So they have these ion channels issues, and that causes these inhibitory neurons and synapses to not really be effective anymore. We get reorganization of all these neural networks after brain injury, also may cause these issues to happen. So someone with an underlying brain injury later on may develop seizures because as the brain kind of healed, the tissue kind of moves in different areas and it wasn't supposed to be because of swelling or whatever. And now we're kind of like setting the stage for these seizures to occur later. Febrile seizures in neonates may be linked to these mutations in these ion channels. So fevers of kids 5 and under, don't worry about so much if they have a seizure with a fever. It's the fever that caused the seizure. It's not the seizure being a problem. These are the febrile convulsions or the febrile seizures. Usually 6 months to 4 years of age, most common about a year and a half. A small percentage occur after 4 years, but here's the key thing. If you had febrile seizures as a child, you have a 1% to 2% lifetime risk of getting epilepsy later on. You kind of already made those circuits, they're already there. They can be activated later. So with these patients, with these young kids with these febrile seizures, you don't really have to investigate minimally. Check your glucose, do your observations. Lumbar puncture only if you have specific worries that they're septic. And that's why they have these seizures and the fever. If you suspect they have meningitis or something going on with the CNS, then you would do a lumbar puncture. But normally you don't do them. Okay, let's take a break. Yes?
Sorry, for the complex partials, you said they're preceded by an aura.
Yep.
Are they generalized? I feel like I've seen videos.
They will have auras too. Okay, come back at 8:55. Okay, so the last two things we're going to talk about is dementia and stroke. So dementia is basically Alzheimer's disease. Dementia is an umbrella term again, just like COPD is. Cor pulmonale is an umbrella term. Dementia is an umbrella term dealing with a bunch of different underlying causes. The most common is Alzheimer's disease. That's why we mainly associate dementia with Alzheimer's disease. 62% of them are there. Vascular dementia is also another big one. What do you think causes vascular dementia? Strokes caused by what? What do we talk about all the time? We got to control. High blood pressure. So high blood pressure causes these vascular strokes. Here's your Lewy body dementia. Is there as well. We talked about that a little bit yesterday with regards to the buildup of the synuclein and the ubiquitin. Here's the key thing. Dementia is not a normal response of aging. Yes, people with age will become forgetful, but there is a clear difference between forgetting things and dementia. But the incidence does increase with age. So as you get older, the incidence goes up, but doesn't mean that you're going to get it. Characteristics, memory impairment. Most of the time, it's going to be a family member that notices it and will bring it up at the doctor's office. Usually the patient themselves won't notice their memory problems. And they may lose one other area of cortical functioning. Language, calculation, spatial orientation, decision-making, judgment, abstract reasoning. These are all things that you will or you've learned or will be learning how to do on a mini mental status exam. What do you do right now that you guys know about on your head-to-toe exam with a neuro checklist? What do you ask them? Alert and orient times 3. So do they know where they are? But what about memory? What do we do? 3 words, right? Cap all tree. I'll ask you again in like 5-10 minutes. That's testing memory impairment. Language. Do they respond to you appropriately? How is their speaking? Does it make sense what they're saying to you? Are they able to articulate their words appropriately? Spatial orientation, we haven't gotten there yet, but on the bigger status exam, they have to draw like interlocking pentagons. You have to recreate a picture. Can they do that? You will get to that in neuro and behavioral health in the winter. Judgment, decision making. If any of you worked in memory care, You'll see that these patients don't act normally anymore because their cortical reasoning is being diminished because of the dementia. Symptoms progress over months to years, and alertness is preserved until late stages of the disease. Then they really don't respond to much. Again, the majority of them are going to be Alzheimer's. Other etiologies, multiple cerebral infarcts. So if you have multiple strokes causing issues, can cause dementia. Dementia with Lewy body, alcoholism. Normal pressure hydrocephalus is a big one to know because it looks like Parkinson's patients. They present with inability to walk normally. But the key thing with normal pressure hydrocephalus is it's treatable. You just do a CT scan of the brain. You're going to see their ventricles are going to be huge and wide. They just have too much CSF fluid. You just draw it off, and they get better. Frontotemporal dementia, obviously affecting the front part of the brain, so all their decision making, social graces are lost. Huntington's disease is another underlying cause that can give dementia, HIV, and some deficiencies. Here's just a way of looking at the different ways that different parts of dementia and follow their trees, underlying causes. So here's the one for Alzheimer's. Major symptoms, memory, adult onset, and then what are the symptoms they get? Memory issues, judgment, disorientation, behavior changes, difficulty speaking. These are the ones that you see walking down the road. They don't know where they're going. They get lost. They leave their house. So obviously, if you know you have a patient with dementia, start thinking about patient education. How are they going to go home? Are they going to be living by themselves? Who's going to take care of them? Not you, but you have to figure out who's going to be the one to do it. So when you discharge them, you have all your instructions. You say, this is going to be taking them home, and blah, 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 stuff like that. So that's that one. Here's your vascular one. Obviously, the issue is your blood vessels with your vascular dementia. Dementia with Lewy body, we talked about yesterday. The big thing with Lewy body is the hallucinations. That is unique to Lewy body. They still may have symptoms of Alzheimer's and Parkinson's, but it's the hallucinations that is the key for Lewy body. Anything else I want you to worry about? Here's your normal pressure hydrocephalus. Symptoms, problems walking, memory loss, and the urinary incontinence. That's the key with normal pressure hydrocephalus. They have urinary incontinence. The other ones don't. And that's pretty much all I want you to know for that slide. The other ones don't worry about for now. So Alzheimer's disease, again, most common form, slowly progressive disorder over 5 to 20 years. Takes a long time for us to go on. 10% of cases are familial with early onset. It happens early in life. I don't know if you guys know who this is, but many years ago, Tennessee women's basketball coach Pat Summitt was like one of the best basketball coaches for women's basketball, even overall. She developed Alzheimer's disease early. I think she was like her 40s or 50s, early on, and then eventually she passed away from it. But again, early onset, it does happen early on. Typically, impairment of learning and recent memory. So anything recent they have trouble holding on to. So anomia is can't recall everyday objects. So what do you do for that? How do you test that? What is this? Stereognosis too. Put something in their hand. Do they know what that is? That's why you have to use real objects. Don't use like reflex hammers or medical stuff because they won't know what that is. Aphasia, loss of ability to understand or express speech. So when you're asking your questions, this is why you ask open-ended question, not yes or no. Yes?
Bruce Willis falls under this, correct?
He has Alzheimer's. Acalcula, can't perform simple math. That comes later on. And again, loss of employment because they can't function anymore. And then obviously issues. This is an artist who developed Alzheimer's and did like self-portraits. And over time, you can see with Alzheimer's how bad the self-portraits got. due to the Alzheimer's disease. So spatial disorientation, they get lost easy. Apraxias, difficulty cooking, cleaning, self-care. How does your patient look when they come to see you? Are they groomed? Are they wearing appropriate clothes? Are they dirty? Are they taking care of themselves? You have to note all these things. So when you write your note, 23-year-old, well-developed, well-nourished male presents with blah, blah, blah. Well, are they well-developed, well-nourished or not? Like, are they obese? Are they disheveled? Are they, anxious? Like, what do they look like when you walk into the room? Gait disturbances may develop similar to Parkinson's. That's why there's some overlap. They have some gait problems. Social graces are lost, so they start acting out. They'll do inappropriate things because they lose it. Psych issues, psych symptoms may appear in later stages, paranoia, hallucinations, delusions. If you know anyone who's got Alzheimer's and they have like a fixation on like a baby, usually a lot of them will like hold on to a baby doll and thinking it's a real baby. Buy like 5 of them, save the 4. Because if they lose that one, it will send them off on a downward spiral. So just have, oh, here it is, we found it, it was here, and just give them their baby. They won't know the difference in 5 minutes. But have backups if they have any fixations. So we talked a little bit about this yesterday when we talked with Parkinson's. These amyloid plaques. And I just found out too, Alzheimer's disease is actually considered type 3 diabetes. I don't know where it comes from, but it's something with the sugar. Over time, it's considered type 3. Look it up, type 3 diabetes. I don't know. I never really heard about it until like last year. You have a question?
I was just gonna ask, because you said that one coach died from Alzheimer's. Do they die from like eventually it affects like more than just?
Well, they just won't take care of it. Later on, they devolve into something called inanition, where they won't eat, they won't take care of themselves, they won't do anything. They just it's over. Like, so that's what happens. So we have these amyloid plaques. Here's our cell body. There's our axon. Our axon obviously has these neurofibrils, they're little train tracks that transport the proteins to different areas. What happens is they get tangled. So we get neurofibrillary tangles. That's one of the symptoms you'll see. Again, you only see this on histology. It's not a symptom, it's a sign. But you won't see it you have to see this on like autopsy. But neurofibrillary tangles is one of the things you'll see with Alzheimer's disease. What else we got here? So we get neuritic amyloid plaques. So we talked about these amyloid plaques. What's inside that stuff? Well, amyloid. I was thinking of the Lewy body stuff. This is not the Lewy body. So we get these plaques that form on the outside, these beta amyloid plaques. These plaques are the link between Alzheimer's and Parkinson's, are these beta amyloid plaques. They both get them. Again, so here's our major protein, that beta amyloid protein, derived from beta amyloid precursor protein. This APP supports the growth of neurites. So is neurite anything projecting from the cell body? That's what these beta amyloid proteins are there for. With the neurites, that's how we receive the information from surrounding neurons. So it's suggested that having an extra copy of this APP gene increases the metabolism of this APP to the beta amyloid protein. So the extra APP gene causes overproduction of this amyloid protein. And this is what likely causes the neurodegeneration to occur. So this is where they have these familial cases. And they have the mutation in the APP gene. So because we are messing up with the neurites, we get synaptic transmission is affected. And we have problems connecting the synapses. Nothing transmits, nothing happens. So here's on autopsy. This is histology. Those are the amyloid plaques. And you can kind of see the little tangles a little bit on those pictures, but not very well. But again, unfortunately, the person has to be passed away for you to get these images. I think new techniques with these functional MRIs are starting to localize these plaques and tangles. But it's not to the point where it's like a gold standard that you start screening these people for these things. It's still a experimental thing. Apolipoprotein E. Okay, I bring this up because this is, what are apolipoproteins? They're cholesterol, but the apolipoproteins sit on top of the cholesterol. They're like a little hat that resides on all different forms of cholesterol levels. HDL has ApoB that sits on top. ApoE is on your other LDL and VLDLs. The reason why I bring this up is because if you have the wild type of this ApoE variant, there is a strong link between the E variant and Alzheimer's. Okay? So ApoE4 produced by astrocytes in the brain, also liver outside the CNS, associated with hyperlipidemia, therefore increased risk of CAD. So it's this increased beta amyloid formation of the tangles. Now, this is where like these genetic screens kind of get weird, because if you do a genetic screen and it shows that you have this ApoE4 wild type variant, that means that your risk for Alzheimer's goes up. That does not mean that you will get Alzheimer's, it just means that the risk goes up. If your insurance company sees these things, they raise your rates because they know you have an underlying cause. So these weird things. But there's another actor, you all know who this one is, who found that he had this ApoE4 wild type and like kind of like took time off from acting for a little bit to kind of get things squared away, and now he's back and everything. But I don't know who this one is.
Is it the Grey's Anatomy guy?
No, but maybe, I don't know. Yeah, you're right. Chris Hemsworth, Thor. Chris Hemsworth had the wild type, and took the, yes.
So I have a question, because I'm still figuring out like the apolipoprotein stuff. So have you talked about like the weight loss and how it like carries like the VLDLs, IDLs, and LDLs? I just want to know like what's the difference between like ApoB?
They're just targets, and when it comes to the liver knows, okay, this is the good cholesterol, this is the bad one.
Okay.
They're just like little hats so the liver knows, get rid of this one, get rid of that one.
Are there normal forms of?
Well, yeah, ApoE 1, 2, and 3 are the or 2, 3, and 2. There's 2, 3, and 4. 2 and 3 are okay, but ApoE4 is the wild type that leads you to have a higher risk.
Okay.
So it's the fourth wild type version of the ApoE that causes the risk. The 2 and 3s don't.
Okay. Thank you.
So this is what a brain will look like with long-term Alzheimer's disease. You can see the cortical atrophy going on that side, widened sulci, reducing the surface area for all these things to occur. So fewer nerve cells, fewer connections, that leads to the Alzheimer's. Last little bit is on strokes. Okay, sudden onset of a focal neurologic deficit. My right arm is numb, I can't move it. My right face is drooping, I can't move it, I can't smile. There's a focal deficit for a specific problem. Persists for at least 24 hours and is due to abnormal cerebral circulation. If it's less than 24 hours, it's considered a TIA, which is a transient ischemic attack. You had the symptom, they resolved on their own within 24 hours, now you're fine afterwards. The problem with TIAs is that it's usually a sign of a bigger stroke that's going to happen soon. So watch out for those. Third leading cause of death, more men than women. Why do you think more men than women have strokes? Hypertension. Risk factors, again, these are going to be your main risk factors for like everything. High blood pressure, high cholesterol, diabetes, smoking, alcohol, oral contraceptive use. Obviously, why oral contraceptive use? Hypercoagulability. If you develop a clot, if you're on the arterial side, it's going to go to the brain, depending on where you are on the arterial side. Here you go. It's altered. It is altered. Okay. So vascular supply is the problem where the brain is mapped. We know the territories of the brain. We know what arteries feed the different areas. Just like you guys do EKG, you can localize what part of the heart is having the problems. We know that with the brain because we've mapped it out. We know that if you're having lower leg problems, we know it's the anterior circulation that's causing the issue. If it's your arms, your face, we know that's your middle cerebral circulation that's causing the problem. So go back to your anatomy, know the roots, know the vessels and what they're doing. There's two major categories when it comes to of strokes. Ischemic stroke is due to vascular occlusion. These are the majority of the strokes are these thrombotic ones. Ischemic stroke due to an occlusion. The other form is a hemorrhagic stroke. This is when you have an open vessel, it ruptured. High blood pressure ruptures the vessels. Hyperlipidemia weakens the vessel walls. You can get dissections going, a whole bunch of weird things. But the vessel popped. Now blood is pouring out into a different area. Both issues cause ischemia downstream. The key thing is the underlying cause. Do they have an occlusion that caused the stroke, or is it a hemorrhage? Did the vessel rupture, and that's what's causing them to have a stroke? And hemorrhagics are harder to predict because there's a lot of risk factors there, multiple factors, location of the bleed. They also get increased intracranial pressure. You're filling up the cranium with blood that's not supposed to be there. It's filling up. The brain is fixed inside a skull. The skull will not expand, so the pressure goes inward and compresses the brain tissue and causes problems. Causes brain edema, compression of neighboring tissues, what I just talked about, rupture of blood and ventricles or subarachnoid space. Those are all different things that can go wrong with a hemorrhagic stroke. So, what causes these ischemic strokes? The main one are these thrombotic occlusions. It could be large vessels, so the bigger the vessel, the bigger the territory that it's going to perfuse, right? Small vessels are small because they have a smaller area of perfusion, where if you like block your carotid, everything upstream is going to be occluded as well and not have any blood supply. The bigger the vessel, the bigger the problem. Small vessels, these are your lacunar strokes. And venous occlusion as well. Embolic strokes is artery to artery or cardioembolic. What's the main one for that one? For cardioembolic. AFib. AFib is the main cause of those cardioembolic strokes. Okay, started in the cardiac system and embolized and went up to the brain causing a stroke. So it's AFib. That's why you give Coumadin for AFib. You have to coagulate that, or anticoagulate them so they don't get clots. Hemorrhagic strokes. Interparenchymal hemorrhage. Here's your subarachnoid hemorrhage, subdural hemorrhage, epidural hemorrhage, and a hemorrhagic ischemic infarction. Obviously, hemorrhage. We know we're bleeding out somewhere. Those things just talk about what layer we're bleeding out of. So ischemic strokes, either from thrombotic or embolic occlusion of the cerebral vessels. So you can see here, if a clot was in the atria, it worked its way out. It can go right up top, work its way up, and then boom, there's your middle cerebral circulation. Middle cerebral artery right there. That's where AFib goes majority of the time, middle cerebral artery. It's right in line, follows the path, and goes right up and causes that type of stroke. Middle cerebral artery causes more issues with the face and arms with his middle cerebral arteries. Symptoms evolve over several minutes, may be preceded by brief episodes of reversible focal deficits, and that's your transient ischemic attack. So they're focal deficit, but they don't last very long. Remember, stroke is over 24 hours the deficit. If it's less than that, it's a TIA. And I talked about that already. 80% of the blood flow to the cerebral artery goes through that middle cerebral artery, and that's where the clots go. So this is another very important one to know. Your anterior cerebral artery circulation is all the yellow. Middle cerebral artery is all the red. Big territory for that middle cerebral artery. And we have the posterior cerebral artery. Obviously, that's our visual area back there. Here's our homunculus. So remember, somatosensory side and the motor side. Okay? Genitals, toes, hips, trunk. I would say up to here. This is all anterior cerebral artery. All this is middle cerebral artery. And it's the same on the other side as well. Here's another way of looking at it. Same picture before, a little bit cleaner, but again, you can look and see where we have the issue. So if they come in with a lower leg weakness, what artery is most likely affected? Anterior. Here's your motor. Here's your leg, foot. It's the blue, anterior cerebral circulation. If they come in with facial droop, middle cerebral artery. Okay? Just like you do with EKG. If it's an inferior wall MI, look for your RCA, right? If it's anterior wall MI, left main, LAD. If it's a lateral wall MI, check that circumflex artery, because that's what feeds that area. And here's another joke for you. Okay, so ischemic strokes. Occlusion of small arteries at select locations where perfusion depends on those small vessels. So we have an occlusion to the blood. These little areas get ischemic and eventually necrosis and they die off. Most are from chronic hypertension, and that's why we are so worried and careful about hypertension, because we know it can cause strokes as well as issues with the heart itself. Most common vessels with the basal ganglia, brainstem, and thalamus are also there. These occlusions are called lacunar infarcts. They can be pure motor or pure sensory, depending on where they occur. So lacunar infarcts are due to high blood pressure. And what happens, these little tiny vessels, they all hemorrhage and pop. And when enough of them in a certain area hemorrhage and pop, the tissue in that area dies off. Whatever area of the brain was affected, that's where you'll have your symptoms. Again, remember the bifurcations. All these deep red areas are the areas of big, where these risk factors are going to happen. Always at these bifurcations, high stress areas due to atherosclerosis. Hemorrhage, okay? On CT, what color does blood show up as? White. CT blood is white. And you can see this all right there. This is all blood from a hemorrhage, because they're bleeding out, so the blood is now leaving the closed circulatory system and getting into the brain parenchyma, and you can see that. This causes a mass shift, so the tissue is being pushed over. And if you look, you can just draw your middle line, and you see how it got shifted to the left. That's mass effect from this swelling, this space-occupying lesion, bleeding, whatever it is, it's pushing the brain tissue off to the side. This will cause seizures to happen and a bunch of other things going on, but this is one cause. This is an epidural hematoma, and this usually is from a tear in the middle meningeal artery. Where's the middle meningeal artery? Okay, on the side of the head, it's very easily broken, so when people get hit in the head really hard with trauma, you can tear that middle meningeal artery very easily, causing an epidural hematoma. Epidural, subarachnoid, what's the difference between the two? What are we looking at? The dura layers. Remember, what are the 3 layers of the dura? Which one's the outer one? And then what's the middle one? And the inner one? Pia. So a epidural is above the dura. Subarachnoid is below the arachnoid layer, above the pia layer. That's why a subarachnoid layer. What fluid is also in that subarachnoid layer? CSF. So you're going to bleed into the CSF from that subarachnoid space. So if I do a lumbar puncture on that patient, what am I going to see? Blood. There you go. Initial loss of consciousness due to the injury, maybe due to concussion, that caused them to lose consciousness, but they're going to wake up a little bit. But then hours later, these people crash hard. And that's due to brain herniation. So they're going to be, it's like they call it a lucid period, where they'll have a trauma, a motor vehicle accident, something where they hit their head. They're going to come in and see you. They'll be passed out at first, but they'll come to, and they may be able to talk to you in the ER. But then a few hours later, they're going to start decompensating, altered mental status, and crashing because of this lesion getting bigger and bigger, risk of brain herniation. This is your subdural hematoma. This usually arises from venous blood that leaks from these torn cortical veins, bridging the subdural space. So subdural, under the dura layer, above the subarachnoid layer, arachnoid layer, I'm sorry. But these ones are due to veins. So this happens a lot in elderly people. We talked about how with aging, there's a normal response for the cortex to shrink a little bit, right? And with Alzheimer's, it's even worse, that cortical atrophy, the brain outside shrinks a little bit. We have veins that bridge that area. And as the brain shrinks, those veins get pulled tight. And they can pop from being pulled too tight. So what happens is in like car accidents, when they go forward and come back, just the going forward, the brain, remember, it's suspended in liquid. It's going to move a little bit. And a lot of what concussions are is your brain hitting your skull. That's what causes the bruise. It's the force of the brain hitting the skull. But in this case, those little bridging veins, because of the whiplash and the force of getting into an accident, makes the brain move, and it can rupture those little veins in that subdural space, causing those veins to leak into this area. These ones can be very minor. They can live with these things for a long time. They usually resolve. We get minor trauma, particularly in the elderly, because they have that cortex thinning. Those veins are being pulled tight, and they can rupture very easily. Very low pressure in these because it's a venous blood, low pressure in them, so they just ooze, whereas your epidural is arteries. Remember, it's the middle meningeal artery. Arteries are under pressure. They're going to lose blood faster with an arterial tear than they will with a venous tear. So this happens fast. This can be slowly developing. May not appear for several days later because that blood is slowly oozing and oozing and oozing to a point where later on they may get symptoms. Here's your subarachnoid hemorrhage. You can see all the blood that's showing up in the ventricular space that shouldn't be there. This is blood in the subarachnoid space. This is usually due to like berry aneurysms. The girl who played Khaleesi on Game of Thrones, after the first season, she had one of these that ruptured, and then she had another one later on. But she almost died after the first season, but then they clip it and they fix it and all that stuff. But these is genetics too. It can also be due to an AV malformation where the arterial and the venous start to communicate. They have a connecting vessel. Those are under different types of pressure, and those can pop as well, causing the hemorrhage. Yes?
Are there preventions for those malformations?
It's genetic, and a lot of times because you don't know you have it until it pops. Now, if someone in her family has it, then you can probably do some screening, but there's no real way to know. There's no antibodies floating around. It's going to You can do scans every year to see if anything's growing. So, the rupture suddenly elevates intracranial pressure. You have all this blood going into the ventricles. It's going to raise intracranial pressure. That's going to go up. That can interrupt cerebral blood flow, causing a generalized concussive injury. With every very large hemorrhages, global cerebral ischemia can cause severe brain damage and a prolonged coma. Usually patients they're very, very poor prognosis if they have a hemorrhagic stroke. Because of the bleeding, can you repair that? This is where you have to like open the brain up sometimes and go in to repair these vessels. Sometimes you can go from inside and do it internally to repair things, but depending on where they are, different things you have to do for treatment. The last type is an interparenchymal hemorrhage, and this is also due to, again, elevations in blood pressure from any variety of disorders that weaken the vessels. Anything that weakens the vessel walls makes them prone to rupture during periods of high stress, high pressure. Hematoma causes a focal neurologic deficit by just compressing tissues. This is just bleeding around the brain itself. Obviously, chronic hypertension is the most common cause. Other causes, vascular malformations. These are those AVMs. Brain tumors as well. Any elderly patient with a new onset seizure, new onset headache, because usually if you've had headaches, you get them throughout your life. If you're an elderly person, 60s and above, whatever, and you've never really had headaches, and now you start getting headaches, get a CT scan to see if there's any brain lesion going on, anything going on. Cocaine and amphetamines cause rapid immediate rises in blood pressure and a lot of the causes for these brain bleeds in young adults. Another one is that cerebral amyloid angiopathy is a disorder mainly in the elderly and may be associated with some Alzheimer's as well. Again, those amyloid plaques weaken the walls of those small vessels. So these amyloid plaques are not good in the cell body on the nerves. They cause disruption in conduction. If they get lodged in the vessel walls, they weaken those walls as well. Excitotoxicity. So when we have a stroke, we have an ischemic area. The ischemic area itself is dead. It's not going to have any, it's not going to come back. What we're talking about here is the area around the stroke. The immediate area that's kind of in that ischemic zone a little bit, but they're not dead yet, but they're undergoing a lot of metabolic things because of all the stress that they're under with the ischemic changes. So most efforts to intervene in strokes have been involved with the vasculature, opening it back up again, getting the blood supply going again. But there's another approach to help save brain tissue from other ischemic damage. So let's say this area of the brain tissue is dead, but this area around it is ischemic changes. They're not dead yet, but they're undergoing this stress. What happens is we found out that they have this excitotoxicity going on, where glutamate goes kind of crazy during ischemia. What is glutamate? Is it excitatory or inhibitory? Excitatory. Glutamate is excitatory, so it's going to excite the tissue around it. But the tissue around it is already stressed. It's already ischemic. So by making it more excitable, what are you doing to the ischemia? Making it worse or better? Making it worse. So we know that now because of these rising levels of glutamate. So glutamate is a major. So what's going on? They're so excitable, they die from energy deprivation. They have no more energy left, but they're still being excited, and they just start to die off. However, the edge of that ischemic region, which we just talked about before, we have that dead area, but the area around it is still alive, and that's what we're trying to protect. Again, excessive stimulation of your glutamate receptors. So ischemia deprives oxygen and glucose. We know that. There's no blood supply. Nothing's bringing that to the brain tissue. Depletes neura and glia from maintaining ion gradients, and results in inhibition of glutamate uptake. what's going to happen to all that glutamate? It's going to stay in the cleft, in that synaptic cleft, continuing to stimulate because we're not degrading it anymore. So it's going to build up in the cleft, continue to stimulate and overexcite those tissues. So declining energy reserves also reduce conservation of glutamate to glutamine and glia. Again, all this is increasing glutamate on the outside. We don't want the excess glutamate. I think we're almost done. So both events lead to increased glutamate. So this keeps exciting. We get more calcium and sodium going into the cell because that's what's supposed to happen during excitation. Depolarizes the neuron, stimulating more calcium influx. Remember we talked about reperfusion injuries. What were some of the causes for reperfusion injuries? One of them was this, increased calcium. What was the other one? Free radical generation. Okay? So increased calcium is a bad thing, leads to reperfusion injuries. So resultant overload in intracellular calcium is toxic. It's too much. Sustained activation of these calcium-sensitive enzymes, including proteases, all start leading towards cell death. So the key thing at the end from all of this is glutamate good during a stroke? No. So we're giving drugs now that are glutamate receptor antagonists during a stroke. What is that going to do? Reduce the effect of the glutamate by getting rid of the receptors to it. So if you block the receptor to glutamate, the glutamate won't have any effect. It's like giving a beta blocker. You're blocking the beta receptors so that it doesn't have an effect on the heart. Same thing here. The glutamate receptor antagonist to help preserve the surrounding zone of ischemia to help with patients recover. And I think that's it. There's no end page? Yes, that is it. Okay. I have one review for us. It's just a Jeopardy review. We'll just go through it fast. It's not that much. Okay. We'll just go through them fast. I'll post it later. Okay. 22-year-old, otherwise healthy female, comes to the ER complaining of blood in the urine. Recently sick, but never went to the doctor. She still feels under the weather and feverish at night sometimes. BP, how's the BP? A little bit high. How's the temp? A little high. Otherwise unremarkable exam. You order a UA. What two findings do you think it would show? Okay. Blood, hematuria, red blood cell casts because of all the hematuria, maybe some protein. Okay, what's the most likely diagnosis for this one? This is your acute glomerulonephritis. She was sick a few weeks ago. Remember, post-sickness, a week or two afterwards, you come in with bleeding in the urine. It's acute glomerulonephritis. What's the cause? Post-streptococcal. Okay, she was sick. That's the most common cause. And what are some other causes for this diagnosis? You guys didn't study any of this yet, so I'll just go through it. Other causes, infective endocarditis, and any other type of illness can cause it as well. These are the most common ones: endocarditis, pneumococcal pneumonia, and sepsis for acute glomerulonephritis. And pathogenesis of this disease process. So this is nephritic disease, right? So is nephritic disease, is it a problem with What is the problem? Is it a problem with the podocyte or is it inflammation? This is inflammation. Okay? These antigen antibody complexes get to the glomerular wall, and that starts the whole inflammation cascade. Destroys the glomerulus, increases permeability so bigger sized particles can get through. Red blood cells can now get through, but they'll get lodged in the tubes, causing those casts to develop. Okay, 8-year-old boy is brought to the ED by his mother due to sudden onset of facial swelling. Okay, when you order a UA, what do you expect to see in a UA in this patient? Proteins, right? High proteins. Okay, 3+ protein, negative red blood cell, negative white blood cells. So this is just proteins being spilled in to the urine for this patient. Okay, you order a 24-hour urine collection. What do you expect to see on this one? High protein. Remember that 3.5 number. 3.5 grams of protein in 24-hour collection is this disease. So you order a blood work on this patient. What would you expect the values of the BUN and creatinine to be? High, low, or normal? Okay. It'll be high. Could be like 1.4. Okay, so the labs come back. Serum creatinine level is slightly elevated, 1.4. Albumin's 2.8. LFTs are within normal limits. Urinalysis is negative but has 3+ protein, 24-hour urine collection, protein excretion of 4 grams in 24 hours. So what's the diagnosis for this one? Nephrotic syndrome on this one with the O. Because of the proteins, there's no blood. This is all a nephrotic disease. So nephrotic diseases affect what? The podocytes. And they make bigger molecules like the proteins get through. And what's the cause for the increased protein in the blood? So we're losing protein in the urine, but now we have a compensation of high protein in the blood. Why do we get that? What makes proteins in the liver goes into production to make proteins? Specifically, which ones will start going up as well? Cholesterol goes up. So they have high cholesterol levels. They may have that lipiduria in these patients where they have all the protein and the cholesterol levels in the urine. So that's where they come from, these ones. Next one. 63-year-old male comes to the clinic with a several-month history of difficulty with his gait and coordination. He finds walking difficult and has almost fallen on several occasions, especially when trying to change directions. So changing directions, what type of movement is that? Intentional. And a coordinated movement. It's intentional, but it's a